Sir. So we'll start the program now. Respected Chairperson Professor Dr. Arun B. Nair, Department of Psychiatry, Trivandrum Medical College, Trivandrum, Kerala. And today's speaker, Dr. Swapnajeet Sahoo, Department of Psychiatry, Postgraduate Institute of Medical Education Research, Chandigarh, and moderator Dr. Vasugi, consultant psychiatrist of Sahoo Main Care Hospital, Tirunelveli. My dear colleagues, practicing psychiatrists, postgraduates, good morning to all of you. I extend my warm welcome to all of you. Indeed, it's a great privilege for me to organize this All India PGIMER webinar. And we have been conducting this webinar for almost 2 years on every fourth Sunday. There is a overwhelming response and support for the webinar among the postgraduates as well as the practicing psychiatrists across India. We are choosing a topic, it is more relevant to the postgraduates. The speaker for this webinar is also well-known and eminent personality. The chairperson for this webinar also a senior-most postgraduate teachers. The webinar is not only beneficial for the postgraduates, but it's also helpful for the practitioners to refreshing themselves. I am thankful to Dr. Arun B. Nair sir from Trivandrum and Dr. Swapnajeet Sahoo from PGI Chandigarh for accepting our invitation to join this program in spite of their busy schedule. Thank you very much, sir, both of you. And today's speaker is Dr. Swapnajeet Sahoo. He is from prestigious Institute of India, PGI Chandigarh, and he is an eminent postgraduate teacher, and he has more than 200 publications. Dr. Swapnajeet Sahoo will speak about the catatonia, current understanding, and hope this topic will be beneficial for the postgraduates as well as for the practicing psychiatrists. The speaker will ask 5 questions during his presentations. The first and quick responder will receive an attractive prize, and the postgraduates enter your correct answer in the chat box. Now we will hand over this session to our my moderator, Dr. Vasugi from Sahoo Main Care Center. It's over to you, Dr. Vasugi.
Yes, sir. Thank you, sir. Dr. Vasugi from Sahoo Main Care Center. And our topic of today's webinar is Catatonia Current Understanding. On that note, I move on to introduce our chairperson today. Dr. Arun B. Nair, sir, is a professor of psychiatry in Trivandrum Medical College and honorable consultant in Sri Chitrai Tirunal Institute of Medical Sciences and Technology. Sir has authored more than 26 books, including Miracle of Human Bonding. And Sir has published research papers in various topics, including adolescent suicide, child abuse, vitamin D and mental health, substance use disorders, psychosomatic disorders, and so on. He has presented several papers on national and international conferences. Sir has authored 5 chapters in medicine textbooks, has conducted more than 3,000 episodes of health and social awareness programs in various TV channels, more than 8 awards, including Occasional Excellence Award of Rotary International, Manava Seva Ratna Purashkaram Award, P. Kesav Dev Award, and IME Media Award. And Sir is certified by ASHA Book of Records for the largest suicide prevention radio program across India. Over to you, sir.
Thank you very much, Dr. Vasugi. At the beginning itself, let me express my sincere gratitude to Dr. C. Paneer Selvan for giving me this great opportunity to be the chairperson of this wonderful session on the recent advances in the management of catatonia. As we all know, catatonia is one of the biggest emergencies which a psychiatrist has to come across during his clinical practice. And catatonia does not happen in only psychiatric conditions. It may be a part of neurological disorders and other medical conditions as well. So statistics show that around 10 to 25% of acute psychiatric disorders can present with catatonia, while neurological and medical conditions also may have a very high prevalence of catatonia. About around 3% of acute neurology patients and 4% of patients who are remaining in the intensive care unit suffer from catatonia. One big problem regarding catatonia is often, especially in an acute care setting, in a medical setting, there is a lot of delay in the diagnosis of catatonia. So a recent study which was conducted among patients in a medical care hospital showed that around 59% of the patients who were retrospectively diagnosed with catatonia were not diagnosed at the right time. And this has led to a whole lot of complications. We know that unidentified and untreated catatonia can lead to a lot of problems, including stasis, ulcers, and worsening of the medical condition to venous thromboembolism, which can even adversely affect the health and lifespan of the person. So we know before the onset of the current treatment modalities, including electroconvulsive therapy and benzodiazepines, the mortality rate of catatonia was quite high. It was around 75 to 100%. But with the onset of modern treatment facilities, including ECT and benzodiazepine, now the mortality has significantly come down, but still it's reasonably on a high rate of around 5 to 20%. We know there are a whole lot of manifestations for catatonia, including the hyperkinetic and hypokinetic and parakinetic manifestations. Treatment modalities and understanding of the neurobiology of catatonia has advanced and improved over the last decades. We know that over the last couple of decades, our understanding of the neurobiology of catatonia is regarding three neurotransmitters. Essentially, the level of GABA in the prefrontal cortex may be a deficiency, an increased level of glutamate, especially the NMDA in the posterior parietal cortex, and of course, dopamine deficiency around the basal ganglia. So most of the therapeutic interventions have targeted these three neurotransmitters specifically, the benzodiazepines for the GABA system, NMDA antagonists, including memantine and amantadine for the glutamate system, and of course, be cautious about the use of antipsychotics, especially powerful D2 antagonists, even if there is a background of schizophrenia. So I'm sure that today's speaker, Dr. Swapnajeet Sahoo, who is a wonderful researcher, brilliant teacher, and a great speaker, would be enlightening us about the recent advances in catatonia. With these few words of introduction, my best wishes to the speaker. I hand over the session to the moderator once again for a detailed introduction of the speaker for today. Thank you very much.
Thank you, sir. Thank you for setting the stage, sir. Before moving on to the speaker introduction, I'd like to announce previous session quiz winners. Dr. Kalaichelvi, Tirupur Medical College, Dr. Vishali, Madurai Medical College, Dr. Jayashree, KAPV Medical College, Trichy, Dr. Sadhana, KAPV Medical College, Trichy, and Dr. Ragaramya, IMH Chennai, Dr. Shika Adil, SSIMS Chhattisgarh, Dr. Pranjal Tripathi, Andhra Medical College, Dr. Vishali, Madurai Medical College, Dr. Kanakalakshmi, GHMC Visakhapattinam, Dr. Bhagyashree, Trinelveli Medical College. So we'll be having quiz today also. And our speaker of the day, Dr. Swapnajeet Sahoo sir, will be asking 5 questions in between the session. And participants are requested to type their answers in the chat box. The first 2 correct answers will be taken into account, and the winners will be announced in the next session. Now, let me introduce the speaker of the day, Dr. Swapnajeet Sahoo sir. Sir is an Associate Professor of Department of Psychiatry in PGI Chandigarh. Sir did his MBBS from VSS Medical College, Odisha, and MD Psychiatry from PGI Chandigarh. Sir has 8 years of teaching experience, received 8 national and 2 international awards, including Young Psychiatrist Award, Young Research Fellowship Award of World Psychiatric Association. His areas of interest include psychotic disorders, licensed psychiatry, geriatric psychiatry, psychopharmacology, biological psychiatry, and addiction psychiatry. Sir has more than 200 publications. With this short introduction, I'll hand over the session to today's speaker, Dr. Swapnajeet Sahoo sir. Over to you, sir.
Many thanks for the kind words of introduction. At the outset, I would like to thank Dr. Selvan for inviting me, giving an opportunity to discuss about this very relevant topic. Thank you, IPS Tamil Nadu. And Dr. Arun, thank you for setting the stage. In fact, you have summarized the entire presentation for today. So let's see what are the updates in the management of catatonia. Catatonia, if you say in private practice, because many of the postgraduate students who are willing to join the private practice, I can say that many patients you can treat miraculously, and the patient will respond dramatically once you treat just by giving an injection of lorazepam. And the patients and the caregivers will be forever indebted to you, because this is the only one test in which we saw quick dramatic response. And what if one patient gets well, then he or she will bring several patients to you. So this is in short how it's a miraculous treatment. So we will be going through brief about the history, because the history of catatonia is very interesting, and its current status in the nosological system is very important to understand, because it itself is a debatable issue, but hopefully now it has been resolved. So let's see. I can see many senior psychiatrists also in the video. Good morning, Dr. Raj Sekhar. Thank you for being here. So let me start. Okay, so what we'll be discussing? We'll be discussing about a broad overview of about catatonia, about its epidemiological aspects in brief, about the neurobiology, classification from the very early stage to current issues, and how it is being diagnosed in different nosological systems, what are the different tools, and what are the various management issues that come related to some debatable issues, some controversial issues, because as I say, it's a syndrome. So now coming to the first, what is catatonia? In between, I will be as informed that I will be asking 5 questions, and shall I say the answers, or it will not be? Shall I not say the answer, Dr. Basu or Dr. Sarma?
Mr. Sir, you can ask, you can reply for the questions after giving the few seconds for the responder, the postgraduate to respond. After that, you can tell the answer also.
Okay, thanks. So coming to the first one, what is catatonia? In Greek, it has been derived from the word katatonos, meaning pressing tight. As you see that the most common symptom or the sign which we see is a rigidity, or the patient present with a posturing type of presentation. It was first described by Carl Baum in 1874. And as I said, there is a neuropsychiatric condition, and it has a complex mixture of motor, behavioral, and systemic manifestations from various unclear mechanisms. Till now, the actual mechanism has not been well established, but there are various hypotheses and neurobiological research also. So we think that catatonia always means that it will present as a hypokinetic or posturing or mutism, but that is not the case. Catatonia syndrome can present as hypokinetic as well as hyperkinetic, because as you see in the rating scale, there are various items which can say that excitement and agitation. These are also some symptoms of catatonic syndrome, or abnormal parakinetic movements, just like stereotypy, mannerism. So all this. So it's a syndrome which can present is a mixture of all these 3 presentations. So as I said, it has been identified in both psychiatric and non-psychiatric issues, in medical neurological condition, also in drug-induced state. Also recently, it has been said that even with antipsychotic withdrawal, clozapine, acute clozapine, immediate clozapine discontinuation syndrome. So it has been seen in various drug-induced states also. And it needs a careful history, examination, lab investigation, and some standardized rating scale. But however, it is still under-recognized and under-diagnosed. Now coming to a brief about the historical facts. As I said, Carl Baum was the first one who described about catatonia, and he coined the term catatonia in 1874. And he has previously recognized this as a form of stupor. And in the French, it means that lack of communication or stupidity. It means that the patient often present with mutism. So they said that there is lack of communication, or this is a stupid person. So he was the first to identify that this is a typical syndrome. Now he observed that most of the catatonic episodes were either preceded by episodes of depression or mania. So in Prognosis, in contrast to the grim outlook, Carl Baum wrote that recoveries in general are quite common. But what happened after that? After that, as we know, that Emil Kraepelin came and he incorporated the Carl Baum concept of catatonia into his concept of dementia precox in 1893, and he included it as a type of dementia precox. As you know, that dementia precox finally it led into 2 types, that is schizophrenia and manic depressive psychosis. So he exerted a persistent influence on the classification of catatonia. So if we compare what were the concepts of catatonia between these two big persons, Carlbaum and Kraepelin. As per Carlbaum, it was independent diagnosis, but Kraepelin thought that it was a subtype of dementia precox. Then Carlbaum found that it is cyclical or episodic, and Kraepelin was of the view that it's a chronic condition. Prognosis of Carlbaum, he found it to be good, but Kraepelin, as the concept incorporated into dementia precox, which he regarded as a chronic deteriorating course, so its prognosis he supposed was a poor. And Carlbaum, he found that it is similar to manic depressive psychosis, but Kraepelin more similar to schizophrenia. I mean, psychopathology is psychomotor, and here it was deficit of will. So these are the main two conceptual variation in the understanding of catatonia in the earlier years. So then came Bleuler. He followed Kraepelin's conceptual model of catatonia. He recognized catatonia as one of the schizophrenic subtypes. And he commented as a rule that catatonic symptoms mix with manic and melancholic conditions. And however, even after different authors argued against this, but clinicians throughout the 20th century, they considered and they believe that it is an exclusive subtype of only schizophrenia. So they thought that it is not included in mania or depression. So the perceived tight bond between catatonia and the diagnosis of schizophrenia became more tight, and this led to the widespread assumption that catatonia is mainly a form of psychosis and is not appropriately classified elsewhere. And because of this, as you can see in the classification nosological system, there is a term called catatonic schizophrenia. So, but the question arises, is it only seen in psychosis? Because all these persons, they described is only a subtype of schizophrenia, and so it is associated till the 1990s. So then came Fink and Taylor, who contributed various studies from 1980s till date. Also, they have been working, and they contributed their various books on catatonia, examination, assessment, various things. So they contributed extensively to the work of catatonia, and they contributed to the inclusion of new criteria for mood disorders with catatonic features and catatonia due to general medical condition. And because of their work only, it was recognized that catatonia could be a presenting feature in depression, mania, and also in general medical condition. So this, because of them, it was addition to the catatonic type of schizophrenia proposed by DSM-4. But now again back to Carlbaum that it is a separate entity in DSM ICD-11 and DSM-5. I will be talking about it later. So initially, Carlbaum discussed that it is not it should not be included in either in dementia precox or schizophrenia or in the manic depressive psychosis. It should be an independent category. And now, as we see, if we see the different nosological system, it has been a separate entity. So again, we are back to that. So long from so many years, we have been considering it in a wrong way. So again, we are back to what he said initially in 1874. So now, how common it is? So although it was described that in adults, it has been underdiagnosed by psychiatrists and other physicians. It has been seen from various studies that in inpatient population of psychiatric ward, mostly in mental hospitals or asylums, previous studies, they have reported as high as 31%, but the recent studies, they show a range between 7 to 15%. And also, it is more commonly found as thought that it will be more seen in psychosis patient. It is not the same. It is mostly seen in mood disorder patient. That is around 30% or 1/3 of the patients of catatonia has mixed mania or mania. And the rate of catatonia in general psychiatric population varies according to the study design and the research criteria has been used. And catatonia is present in 10% of the acutely ill psychiatric patients, and only a minority of whom have schizophrenia. But in general medical condition, if you do a survey in your own hospital, in medicine wards and surgical wards, or in acute wards, and you will see that if you just apply the Bruce Francis catatonia rating scale, and you will find that around 25% will have catatonic, diagnosable catatonia based on the rating scale. So that's the fact because it is not diagnosed and not reported. So but it is not uncommon also in child and adolescent population because various studies have found a incidence rate to be 0.6 million per year. And the psychiatric population in the children, mostly in the autism and intellectual disabled patients, they have been ranging from 0.6 to 17%. Of late, the prevalence range is 6 to 18% in the different meta-analyses. So what are its causes? The broad etiological and neurobiological aspects will be discussing in brief. So as we know that the etiology of catatonia can be psychiatric or non-psychiatric. So psychiatric conditions are bipolar disorder and mood disorder and major depressive disorder and schizophrenia. So these three conditions, they together form, if the catatonia is present in this condition, it is known as the primary catatonia. And if it is present outside or due to any medical condition, then it is known as secondary catatonia. So the other causes of catatonia or the organic etiology are the CNS injury because of neoplasm, space occupying leisure, or seizure disorder or in stroke, and substance use or drug withdrawal, mostly in substance MDMA or PCP withdrawal due to sedative hypnotic like benzodiazepine withdrawal. Endocrine causes are mostly Addison's, switching. Infectious etiology, mostly cerebral malaria. It has been very commonly seen, and there are various case reports and case series of cerebral malaria presenting with catatonia, which is quite prevalent in India, and neurosyphilis, HIV encephalopathy. So these are the various infectious causes. So if you just do a prevalence study in your own hospital also, in infectious ward also, you will find various prevalent rates of catatonia. So next, coming to what are the various neurobiological aspects which have been studied. So neuroanatomical studies have been done, and they found that with the onset of catatonic manifestation, all these regions are found to be involved, mostly the frontal, parietal lobe, prefrontal cortex, basal ganglia, pons, cerebellum, corpus callosum. And so it was postulated that it is due to dysfunction of neural circuits with involvement of multiple structures rather than any focal alteration, which is not only one area which was involved. There are various areas which have been postulated for the presentation of catatonia. Now, studies, these are the four main regions, that is the lateral orbitofrontal cortex, premotor and motor cortex, because they are mostly associated with the motor activity. And the sensory motor area, then the posterior parietal cortex. So these four areas are the important structures which are involved in the catatonic presentation. Now, if we divide which area is gets affected, then can present with what symptom of catatonia. So some authors have researched and they have tried to pinpoint if this area is affected, then this gives rise to this presentation. So let's see. First is if the dorsolateral prefrontal cortex or the anterior cingulate gyrus or the medial orbitofrontal cortex is affected, then akinetic mutism, or what we commonly say as mutism, and this autonomia is usually seen. Then if striatum is affected, then it leads to movement selection, preparation, and executive planning. Then if lateral orbital frontal cortex is affected, then it leads to imitative and repetitive behavior, which we commonly see as perseveration in catatonic patients or ambitendency. Then if the supplementary motor area or the posterior parietal cortex is affected, it is present with rigidity, initiation, termination, difficulty in termination of movement. And lastly, if the ventral tegmental area is affected, it leads to regulation of affect. It can lead to emotional lability also during this patient, goal-directed thinking, positive reinforcement. And if the substantia nigra, which is a part of basal ganglia, is affected, it leads to difficulty in movement, initiation, and regulation. So as you see, that is the syndrome. So in many patients, not all these areas will be affected. So which area will be affected? They will present with those type of presentation. Many patients may not present with mutism. Many patients may not present with rigidity. So this basic concept we need to know. This common usual notion that those patients who present with rigidity and mutism are only having catatonia, that has to be stopped. So we should think beyond it. So when we come to the actual neurotransmitter which are affected, because these areas have been governed by various neurotransmitters. So it has been seen that in the prefrontal cortex, low GABA activity is seen. In the basal ganglia, low dopaminergic activity, and the parietal cortex, high glutamate activity is seen in catatonia. So what are the implication of this? The implication is this, that a top-down modulation of basal ganglia is proposed, and it was seen that the various researchers, they have studied the animal models of catatonia by inducing catatonia. They have seen that if there is a cortical deficiency of GABA, which is the main inhibitor neurotransmitter, and its hypoactivity in the GABA receptor explain the motor symptom. And because of that only, the benzodiazepine, which increases the GABA activity, benefit the patient with catatonia. So this is the main mechanism, that in the motor areas, there is low GABA. So if you increase the GABA by giving benzodiazepine, and they improve. Another hypothesis and implication is that we see dopaminergic hypoactivity in the T2 receptor, and it is caused by sudden and massive blockade of dopamine. So this is mostly if you give dopamine blocking antipsychotics, because of which we don't usually recommend in giving in catatonia. Because if we give more antipsychotics in catatonia, then it will exacerbate the dopamine deficiency and can worsen the condition. And because of this, we usually don't recommend that you should give dopamine agonist, dopamine antagonist, that is the antipsychotic, in patients with catatonia, and unless it is mostly related to antipsychotic withdrawal catatonia. Another is the glutamate hyperactivity, because the primary excitatory neurotransmitter hyperactivity is the NMDA receptor, which is the recent most finding. It has been suggested as the underlying neurochemical dysfunction, and based on that, there are various drugs which have been found to be effective in treatment of catatonia. Now coming to classification, it is the most important segment. So as I have said in the history part, that in 1874, Carl Böhm first recognized it as a good prognosis with multiple etiologies. Then came Kraepelin, who subtyped as dementia precox, then Bleuler, which was the most were a follower of Kraepelin. Then because of their work in DSM-1, it was included in reaction subtype of schizophrenia, and it was carried forward in DSM-2 up to DSM-3. Then because of Fink and Taylor in 1991, they argued that it is a syndrome, not a schizophrenia subtype. And finally in DSM-4, it was also included as schizophrenia subtype, but also in addition to secondary to medical condition and modifier of affective disorder. Fink and Taylor again continued their research, and they found many phases of catatonia. But as time progressed, it was more clear that it is more commonly a consequence of mood disorders rather than schizophrenia. Although historically catatonia has been regarded more strongly with schizophrenia. This bias giving schizophrenia an exaggerated place in the discussion of catatonia, and it continued to be reflected in ICD-10 and the DSM-4, because ICD-10, as you know, it also came in the year 1992. So it also followed whatever DSM-4 concept was included. So in classification, as you know, in ICD-10, which is also now we should not be following it because we are already with the ICD-11. But we need to know that it was regarded as a subtype of schizophrenia because of the previous work, and the catatonic stupor, schizophrenic catalepsy, schizophrenic catatonia, all these words were used. And also it was found that it was also suggested that if suppose a patient with severe depression is in stupor with catatonic symptoms, and diagnosis of severe depressive episode with psychotic symptoms was made, even if the patient did not have any delusion or hallucinations. So the thing to note is that catatonia was still then regarded to be a psychotic-like symptom. So it was suggested that if a depressed patient presenting with stupor or catatonic presentation, then we need to diagnose that he is having psychotic symptoms. Similarly, a patient with manic stupor will be diagnosed as mania with psychotic symptoms. So these were the various issues, and we had been following ICD-10. So then, thus for depression and mania, only stupor or catatonic presentation were the most extreme of the catatonic signs, which seems to have diagnostic implication, and they did not consider any other signs and symptoms. Whereas for schizophrenia, as you can see, they consider even waxy flexibility, mutism, and many other things. So, and catatonia due to physical causes was diagnosed as organic catatonic disorder under the F06.1, which was included in the delirium segment of the dementia subcategory. Now, what happened in DSM-4 also, it continued the same, and they also included one separate one as NMS was included in the drug-induced movement disorder. And now what happened, another was that continuing because Fink and Taylor also continued with their research, and they considered 3 different subtypes of catatonia, although these are not included in the classificatory system, but we need to know because many often in the postgraduate examination or viva, the examiners usually ask what is malignant catatonia. So these things you need to know. So these are the non-malignant catatonia, which is known as retarded catatonia, delirious mania, and malignant catatonia, which includes neuroleptic malignant syndrome, toxic serotonin syndrome, lethal catatonia. So this because malignant catatonia, because there is a high mortality rate. So another school came, that is the Wernicke-Claes-Leonard school, and they further divided catatonia based on their observation of systemic catatonia and periodic catatonia, because they found some patients, they have recurrent episodes of catatonia, which is known as periodic catatonia, and they found it to be genetically linked with the 15q15. And it was mostly seen with females and mostly with schizophrenia patients. Another one was the systemic catatonia, which is less genetically determined and high prevalence in the males and mostly associated with gastrointestinal, mid-gestational infection. Now, coming to the most recent updates in the DSM-5, because they finally identified and finally separated from it into a separate entity, and they found it that catatonia associated with another mental disorder. Earlier it was another medical condition, now it is another mental disorder. So catatonia is a catatonia specified, which you can add with any of the patient presenting with any diagnosable psychiatric disorder. So this is the recent most change. And as you see in catatonia and DSM-5, now they define that if you present with 3 or more of the following, that is 12 criteria, they have found they are mostly derived from the different rating scale. So if the patient present with 3 or more, then you can easily diagnose catatonia, and you need to know the definition and how to examine them, because this is outside the purview of this webinar. Because there could be a separate webinar on how to assessment for catatonia based on the different signs and symptoms, how to assess for negativity in posturing. So that those are very interesting things to know. And then if diagnosis can be due to general medical condition, it can be added with specifier in schizophrenia, schizoaffective, brief psychotic disorder, in major and all this. So you can diagnose catatonia now with all these disorders. Now, if you compare DSM-5 and ICD-11, that if you can see here, these are the number of items which have been in DSM-5, that is 3 out of 12 if it is present, then you can diagnose schizophrenia. And ICD-11 went ahead, which was recently published in 2022. They also followed this at DSM-5, and they recognized this to be a separate entity and can be associated with schizophrenia, mood episode, neurodevelopmental, medical substance, unspecified. And they included more signs and symptoms, that is 15. And those were ambitendency, verbalization, and automatic obedience. So these 3, they were extra added in ICD-11. So they have increased the threshold. So they have reduced the threshold by increasing the number of signs and symptoms. But here also the minimum threshold to diagnose will be 3. If patient has any 3 of these symptoms, then you can diagnose catatonia. Now there are other types of catatonia. Those are chronic catatonia, because they are mostly present with speech abnormalities are present in speech prompt and speech sluggish type. Autistic catatonia mostly present with neurodevelopmental problems. Ictal catatonia, if it is seen with seizure in post-seizure because of the involvement of the limbic system, usually a manifestation of non-convulsive status epilepticus. And idiopathic catatonia, in which you cannot fit catatonia into any of the existing classification system, and this catatonic symptom occur in absence of any identified psychiatric syndrome, and they become a diagnostic and a management issue. So these are some of the other subtypes of catatonia which have been discussed in literature. Now, these are the different lists of medical conditions and substances which can induce catatonia. That is, substance or medication induced catatonia, that is CNS depression, intoxication, including alcohol, antipsychotic, abrupt withdrawal of antipsychotic like clozapine, withdrawal of benzodiazepine, lithium toxicity, opiates, levetiracetam, azithromycin, and so on, even methylphenidate. So there is a long list, endless list which can induce catatonia. Ahead. Now, coming to different clinical features, as I have already discussed, because these clinical features are present in the diagnostic criteria. So we need to understand what all these symptoms are. So I will not be going into detail of it because these are mostly super excitement, mutism, staring, posturing, grimacing, rigidity. Another concept of psychological pillow, in which the patient, these are the posturing, which can be seen in the earlier editions of your Kaplan and Sadoff. If you can find the seventh or eighth edition, these photos are there. But now it is you may not be seeing it. And this is psychological pillow. As you can see, the patient feels that there is a pillow, so they can be remain extended for extended periods. Other are the ambitendency, workspace flexibility, automatic obedience. There you can see, you can just search the YouTube for any examination of catatonia patient or automatic obedience. You'll be able to know what to give the instruction and how to elicit the response. So every PG student should know how to evaluate or assess a patient with catatonia. So these are the different signs and symptoms of clinical features. Now, we did a study that to find whether there was any difference in the clinical features in different types of catatonia based on etiology, that is, a psychotic, affective, and organic disorder. So we took around 140 total patients, and in which 53 were in psychotic, affective were 45, and organic were 42 because of various illness, mostly neurological illness. And we first tried to find out which were the first catatonic symptom to appear. We asked the family member or the caregiver what they noticed the first, and we regarded those are the first catatonic symptom, and they found that around most of the 60% they found that immobility was the first catatonic symptom, which was present in almost all the types of catatonia, and perseveration was more found in psychotic disorder patients, and slow to respond was also there. So these were the first catatonic sign was found. But in what we found in the results that we could not find any significant difference in the prevalence and severity of various catatonic symptoms in psychotic and affective disorders, which justifies that both these groups of patients, even whatever be the etiology, they may be presenting with the same clinical features, except for the higher prevalence and severity of posturing, which was mostly seen in patients with psychotic groups. So this thing we need to understand that patient may be having different etiology, underlying etiology, but the signs and symptoms and the clinical features are often the same. Now coming to diagnostic tools which have been used, till date there are around six different catatonia rating scales based on which have been evaluated, and the internal reliability is quite high. And they have been used to identify people who have been with catatonia which may not have been diagnosed. So these are the 6 tools. At least you need to remember the Rogers catatonia scale, the Bush-Trans catatonia rating scales, and the Northrop catatonia rating scale, because these are commonly used. Rather, as you can see, the Brownick catatonia rating scale, Canner scale, which is mostly used in autism. So the commonest one to use is the BFCRS, the most widely used. It has 23 items. Shorter version is of 14 item screening version, and any presence or absence of item from 1 to 14 is used for screening, and 0 to 3 is rate the severity, and it has been well established validity. Now, when we compare all these scales, rating scales, you can see that the threshold for catatonia definition in BFCRS is more than equal to 2. So they think as per BFCRS, if the patient has more than 2 items positive, then you can diagnose catatonia. And in Northrop, it is 1 item in each category and total score of more than 7. Then it has number of items are 40. And in BCS, that is 4 criteria. So which rating scale you are using, and similar same is which rating scale has been used in a different studies, they found a different prevalence rates of schizophrenia. So this is the basic picture we need to understand, but we commonly follow BSCRS. Now, differential diagnosis, as I said, that it can be malignant hyperthermia, which is usually autosomal dominant, transmitted muscle sensitivity to inhalation anesthetic and depolarizing muscle relaxant. It's often we see in those who have after post-anesthesia effect, and they present with immobility, mutism, altered mental state, occurs after a surgical procedure and confirmed by muscle biopsy. So They also have similar clinical features of catatonia because immobility, mutism, if they are present and altered mental state, you can diagnose catatonia. But it's a differential diagnosis because the treatment is completely different. Then stiff person syndrome, here also it is need to know because they have painful spasms and associated with rigidity. And patients with catatonia don't usually complain of pain. So they don't respond to benzodiazepine, they live with baclofen. Autistic patients also present with mutism, immobility, echolale, echopraxia. Then these symptoms are chronic with onset in infancy. So you need to take a careful history. Parkinson's also, immobility, altered mental state, comorbid mood disorders can also be confused with catatonia. But here, the cogwheel rigidity is usually seen, and this rigidity does not go away by giving benzodiazepine. Toxic serotonin syndrome, this has been described. It is mostly the prominence of gastrointestinal symptoms, and this descriptive practice is still poorly defined. Neuroleptic malignant syndrome, we all need to know because it's a medical emergency and the mortality rate is very high if we don't treat. It is considered as one type of malignant catatonia. It's mostly associated with exposure of antipsychotic drugs which cause dopaminergic blockade. They usually present with different severe agitation, increased bowel sound, hyperreflexia, tremors, slowness, autonomic instability, tachycardia, diaphoresis. So next, coming to management, and this is the most important segment. So how to manage if we have diagnosed and how to manage. So this is the latest recommended evidence-based consensus guidelines for the management of catatonia, recommendation from the British Association of Psychopharmacology. As you can see, Rogers is the main author of this guideline, and he has also a scale known as the Rogers catatonia rating scale. And we have from India, from our department, we have a Professor Sandeep Rogers, and also from India, we have Neeraj Ahmed. So there are some Indian authors also who have recommended for this guideline, and because it's a comprehensive guideline, we need to know about it because no other APA, NICE guideline, even Australian guideline, Canadian CanMed, they have not given any guidelines how to manage catatonia. This is for the first time the British Association of Psychopharmacology has devised the guideline, and this is a evidence-based consensus guideline. So here they have first written that we need to assess catatonia, that is based on the previous psychiatric and medication history we need to take in detail. We need to evaluate the family history of psychiatric disorders, developmental history, investigation to rule out organicity, investigation to look for NMS, and assessment of occurring medical and physical problems. So here they have given a good table what to elicit from the history from the caregivers. We have to ask about the personal and family history, any psychiatric condition prior to catatonia or any NMS, mood disorder, psychotic disorder, neurodevelopmental disorder, any prior history of ECT or response to such catatonia, neuromedical condition if the patient has underlying seizure disorder, any CNS pathology, encephalitis, autoimmune, on lupus, because lupus vasculitis is also present with catatonia. In personal history, we should be asking if the patient is taking any psychotropic drugs, including lithium, any antiemetics, because it has been seen even domperidone can also precipitate catatonic symptoms. There are various case reports. Clozapine discontinuation also present with catatonia. Benzodiazepine, alcohol discontinuation, other medication like immune checkpoint inhibitors, recreational drugs like stimulant, cannabis, any sexual history we need to take about people if we suspect syphilis or HIV. Now, you have to do a thorough examination, and based on that, we need to do a proper input-output chatting. The patient has to be admitted because it's a medical emergency. You can either admit in the emergency ward or you can admit in inpatient if the patient you see is very unstable. And we need to check about the stats of the 24 hours period, vital signs and incidents. Or you need to have an observation. The patient should be situated near the nursing station, and you need to have a observe the patient, because many of the signs and symptoms of catatonia you can directly diagnose just by mere observation. You can observe the patient for 15 minutes and you'll be able to diagnose various signs and symptoms, at least for a brief period each day, and record the 1 week MSC. In MSC, we usually follow the Kirby's method for uncooperative patients. So what to do with the physical examination? Volume, nutritional status, temperature, cardiovascular examination, respiratory status, Neurological examination for in localizing sign, mostly in if you suspect seizures or CNS tumor. Evidence of deep vein thrombosis if the patient has been immobile for a longer duration, and pressure ulcer. You need to rule out because it can be a septic foci. And we need to take from the history, we have to rule out organicity, or you have to do some of the basic tests, laboratory investigation. Herpes proforma, we need not be forgotten. Physical examination to localize neurologic signs, biochemical investigation to rule out any metabolic abnormalities, because many patients, because they don't eat or drink, they may be having hyponatremia and various electrolyte disturbances. We need to do a hemogram to look for the nutritional factors. Also, if the patient has a history of fever, then we need to rule out malaria and infection. Typical level we can do if we suspect NMS. If the patient is having fever, agitation, we need, and there is a history that he has been subjected to antipsychotic, we need to rule out NMS. EEG usually done if you suspect seizures, and CT or MRI if you suspect space occupying lesion, lumbar puncture if you suspect meningitis. So this is it, because all these patients can have different etiology, and based on case to case basis, we need to do different laboratory investigations. So as I have said, just by observation, if you observe pre, during, and post-exam, just by observation as per DSM-5 and ICD-11, you can diagnose stupor, agitation, posturing, mannerism, stereotypism. I think in ICD-11, you can diagnose impulsivity, combativeness. If combativeness means acute aggression, staring, verbigeration. Elicit, you can elicit by doing examination, mutism, negativism, which can be both acute and active and passive negativism. Active means in response to your instruction, if the patient is not following the instruction or registering, and passive is by himself is not doing it. Echolalia, echopraxia, and ambitendency in ICD-11, and physical examination catalepsy. So these are all things we need to understand that, but by observation also, you can diagnose catatonia. Now, primary versus secondary catatonia, how you need to differentiate based on the investigation and assessment. In primary catatonia, patient responds to painful stimuli. Patient usually keeps his eye open most of the time. Patient reflexes will be normal. No focal neurological deficits will be seen. EEG pattern is of awake state. Lorazepam injection improves or continues to be same, because many patients just don't have good response to lorazepam. So these things you need to know, that if the patient usually responds to this dictum of this six, what we have accumulated from our teachers and from our things, that this usually fits into primary catatonia. And if the patient is reflexes are abnormal, or there is focal neurological deficit, then it is usually organic etiology. Now, management, benzodiazepine, ECT, antipsychotic, antidepressant, which are a debatable and controversial issue. So we'll be discussing benzodiazepine. The first is that we need to admit, we need to investigate to exclude all this organicity, withhold any illicit drugs which are likely to precipitate or worsen the episode, and withhold to avoid any medication. We should maintain hydration, and we should few words about the lorazepam challenge test, because whenever you are asked what is the reference, how you are doing it, people don't know. So this evidence-based guideline have given the reference how to do it. Actual, this is that you have to first assess the catatonic feature using a standard instrument, that is the BFCRS, that administer either 1 to 2 milligram of IV lorazepam if you are giving. If IV is not accessible, then you can give IM 1 to 2 milligram, or if IM also you are not able to do, then you can give 2 milligram of oral. Then you have to reassess. The time is different. If you are doing IV lorazepam, then reassess after 5 minutes. And you are giving IM, then reassess after 15 minutes, and you are giving oral, then reassess after 30 minutes. If there is 50% reduction in the BFCRS score, then that is the test is positive. That is, patient response and answers and oriented and coherent, and the result can look miraculous. And if the response is very less, then it can be negative. That patient often simply falls asleep, and 20% patients have negative results. So a response to benzodiazepine is positive in 2/3 cases, and that is also, even in organic catatonia also the response, but the response rate is quite low as compared to primary catatonia. So tried benzodiazepine have been mostly lorazepam, diazepam challenge test is also usually done, because they also come in IV, and zolpidem. These are from our evidence from various case series. Good response in acute catatonic state, organic catatonia, affective and shorter duration of illness. but not good response if it is secondary to schizophrenia, chronic catatonia, who respond mostly to ECT. Then if the patient fails to respond and inadequate response at 20 milligram of day, then bilateral ECT is usually warranted. You can continue lorazepam either IV or oral maximum for a week if the patient has responded. But again, if it's not improving much, then usually ECT will come to the rescue. And if the ECT patient responds to ECT with first treatment, then at least 6 sessions should be administered. But if the patient fails to lorazepam and ECT, then a trial of memantine, carbamazepine, or topiramate as monotherapy or combination with lorazepam ECT should be attempted. And usually the patient responds to medication or ECT, they should be continued for 9 months, 9 to 12 months, or on ECT for 6 months. Because there are various studies which have shown that the patient relapses with catatonic symptoms as soon as ECT is stopped. So the drugs which have been used as a secondary measures that like amantadine, because it is based on the NMDA receptors, the dose is usually 100 milligram every 3 to 4 days. Maximum dose is 400, memantine, topiramate. Now, this is the broad overview of how to diagnose. So if we clearly look into it, this is first is that when you suspect altered level of behavior, then you first put up the criteria if the catatonia is more than 3 features, because 3 is the threshold in both ICD and DSM. Then if it is unclear, then you can also give lorazepam challenge to see it. And then also if the patient may respond, may not respond. But if the patient responds, but if the catatonia is more than equivalent to 3 features, and if it is no, then it should consider alternative diagnosis. But if it is yes, then we have to interact with the patient as if they're aware, because minded, they may be able to understand your behavior. So should not be doing any activity which the patient might feel offended. So they are in an aware state, but they are not able to respond. So appropriate legal framework needs to be followed when the patient is unable to make any decision as per the new our MSP Act, and you need to follow all the procedures. And if it is first episode and diagnosis is unclear, then you should consider neuroimaging and auto antibodies in CERAP and CHF. If the risk factors for seizures are there, you need to do a EEG and lorazepam challenge if it has not been done before. Then you need to promptly treat it. So you have to treat by giving lorazepam, and if the patient responds, you have to treat the underlying disorder. And if there are any complication of catatonia, just like ulcers or any bed sores, then you need to manage them, or nutritional status or electrolyte imbalance, you need to manage that. And in case of special cases like antipsychotic induced catatonia, you have to stop the antipsychotic and give benzodiazepine. In benzodiazepine withdrawal catatonia, you need to restart benzodiazepine. In chronic mild catatonia and schizophrenia, you have to give directly clozapine trial. That clozapine withdrawal catatonia, you have to restart clozapine, and then followed by ECT. In malignant catatonia, you have to stop dopamine antagonist, and followed by lorazepam and ECT. In NMS, you have to stop dopamine antagonist and anticholinergic. And so these are the various special cases and what to do. It has this guideline has mentioned. And lorazepam followed by ECT. Many patients, even without ECT, they also respond to lorazepam, and ECT may not be required. So you have to reevaluate your diagnosis when the patient again becomes aware, and based on that, you need to do the treatment of the underlying cause. And if the patient does not respond to both of this, then last option is NMDA receptor antagonist like amantadine has been tried. And in case of periodic catatonia, the evidence basis for lithium is available from there is a source from case series and expert opinion also that lithium works in patients with periodic catatonia. Now, prognosis, it indicates expected outcome after appropriate treatment with benzodiazepine or ECT. Mostly the mortality morbidity varies as per the etiology. So if it is a mood disorder with catatonic manifestation, the prognosis is very good and mortality is very less. General medical condition, the prognosis is good to poor, but the mortality and morbidity is very high. In schizophrenia, it is good to fair, and it is very moderate. In malignant neuroleptic syndrome and serotonin syndrome, the prognosis is fair to poor, but the mortality is very high. Now, some debatable issues, like if the catatonia is reclassified as a separate diagnostic class from schizophrenia, then if the patient with schizophrenia presents with catatonia, so what will be the diagnosis? You have to diagnose now as per the nosological both schizophrenia and catatonia. So the patient will carry a 2 diagnosis. Similarly, anti-NMDA encephalitis cases are on the rise. We have several reports. and they have been, even though these patients with anti-NMD or encephalitis, they have many signs and symptoms of catatonia in almost all the patients, but still they have not regarded catatonia as one of the diagnosable signs and symptoms. So this is also one of the debatable issue, whether it should be included under the. So concluding today's talk is that it's a syndrome of motor dysregulation existing for years and is associated with various pathophysiologic processes. Despite its low incidence, it's a serious diagnostic and treatment challenging condition. It can be reliably identified as a typical course response to specific treatment, but is also worsened by other treatments. So if you don't know how to treat, then you can be causing more harm. So first diagnose it and give the appropriate medication. Otherwise, if you just give antipsychotics, then it can kill the patient. So largely underreported because of lack of clinical suspicion, and it has now been hopefully a separate entity in ICD-11 and DSM-5. So we may be expecting good research in this area in the coming decade. Thank you. I'm free to answer any questions.
Thank you, sir. That was an enlightening lecture, sir. We have few questions in chat box, sir. Due to time restraints, we are allowed to take only 5 questions, sir. Shall I read them, sir?
Yeah, sure.
How to identify periodic catatonia? Like, is there any specific number of episodes of catatonia to occur to term it as periodic catatonia, sir?
This concept was discussed in the late 1980s by a certain group of authors, and they have seen that periodic catatonia is usually seen in patients with schizophrenia or psychosis, and they have been mostly seen in females. And when doing any genetic study, they found that the chromosome 15, which is also associated with schizophrenia, was found in them. So there is no such definitive diagnosis of called periodic catatonia or recurrent catatonia in the nosological system. But only thing is that this patient present with brief episodes of catatonia, and they usually don't have any positive symptoms. They usually have most of negative symptoms and catatonic symptoms. So of late, it is now we are not seeing, but we see very few patients who have present with periodic catatonia and they respond to ECT, and few studies have shown that lithium works in this patient to prevent episodes of catatonia in future.
Thank you, sir. Then another person has asked, kindly explain autoimmune disorders and catatonia, use of empirical steroids in the same.
Autoimmune disorders, as I said, NMD encephalitis. Many autoimmune conditions can also present with catatonia. See, I say catatonia is a syndrome. So if you diagnose it and the patient, even if patient is aware, oriented, but is not able to move his limbs or having rigidity, not able to follow commands. So it's a very pathetic condition. Patient is able to understand but not able to do. But just by treating with appropriate medications like benzodiazepine, you are relieving some of the symptoms of the patient, and after that we need to treat accordingly as per the autoimmune condition. So this will improve. The only thing is that we don't suspect that this patient is having catatonic signs and symptoms. So medical doctors should be more aware of these symptoms also.
Okay. How many ECT session will you plan for catatonia, and how to answer this question in exams?
Minimum of 6 ECTs. Usually the patient responds. The patient may respond even with 1 ECT also. But if you stop, the patient will relapse. So usually a course of 6 ECTs is given. And if the underlying etiology is of psychosis nature, then you need to follow it up to even, we have, in our experience, we have given up to 12 ECTs also. And if after that, we need to taper it up by giving twice a week or once a week, then you gradually stop. Otherwise, the patient usually relapses. If the patient presents with depression with catatonia, they dramatically improve with 6 to 8 ECTs. So there is a range. There is not a specific answer for that. Usually 6 to 8 ECT works. And if it is a psychotic illness, then usually the number of ECT sessions should be more.
Okay, thank you. Is there any treatment strategies for management of recurrent catatonia? Patient already on lorazepam, memantine, ECT.
Sorry to say no, but we need to do a thorough autoantibody panel, and also we need to do a genetic workup, because of late I have published a recent case report in IGP, and this female presented with recurrent catatonia was wrongly treated in the neurology as having catatonia or some seizure disorder, something like that. But there was no clear-cut episodes of seizure, and they were referred. And when we admitted the patient, we also thought that we have, because the patient has negative symptoms, not eating, not moving, a sudden change in behavior. So we thought that this is a adolescent onset psychotic illness. And but patient was not improving even with ECT. And if we decrease the number of sessions of ECT, the patient again have relapse of catatonic symptoms. So we did a genetic workup study, and we found it to be patient has familial encephalopathy inclusion bodies, which is a very rare entity, and it is hereditary. So whenever there is a clinical suspicion patient is not improving, you need to do a thorough genetic workup and autoimmune panel. So that's the dictum. So earlier we were not doing this in India because of various cost issues, but now because of these various Ayushman Bharat or something packages, we are able to do, and this is benefiting. Otherwise, we will also thinking that we would have also thought that this is a case of schizophrenia, young girl, 23 years with negative symptoms, and catatonia will be thinking and will be loading with antipsychotic and clozapine. But because of this test, we are able to know that it's a hereditary condition and she will not improve. So in her case also, it was recurrent catatonia, but there was an underlying hereditary genetic condition. So you should think about it.
Thank you, sir. There is one more question, sir. How to differentiate excited catatonia from mania?
Mania, as you know, that patient will be having excessive speech output, grandiosity, goal-directed activity. But in excited catatonia, only will find excitement running here and there, or severe aggression will be there. And if in mania also, we don't usually diagnose catatonia in mania. But if we clinically see that the patient has brief episodes of immobility, posturing, and brief episodes of abrupt excitement running here and there without any aimless, purposeless. So if you apply the BSCS, you'll be able to know that patient with mania also have catatonic signs. So excitement should be purposeless, aimless, abrupt, without any motive. But in mania, they have a motive. They will be able to answer, we are doing this, we are going there because of I have to do this. But in excited catatonia, they don't have any answer to that.
Okay. Thank you, sir. Thank you for answering all those questions. Now I invite our chairperson, Professor Dr. Arun B. Nair, sir, to give concluding remarks.
First of all, my hearty congratulations to Swapnajeet Sahoo for this very exhaustive, elaborate presentation, which covered all aspects of catatonia, ranging from psychiatry to NMDA, encephalitis. So I'm very glad that you brought up the issue of NMDA encephalitis also, because as I am a consultant in the Sri Chitra Tirunal Institute of Medical Sciences, we get a lot of cases of NMDA encephalitis presenting with behavioral symptoms. And this is one condition where many psychiatrists have burnt their fingers also. My humble request to the young doctors here is, be aware of the possibility of an anti-NMDA encephalitis, because very recently, 3 months back, a medical student who was studying in Pondicherry presented with behavioral symptoms to a big hospital in Kochi, Kerala. And she was seen by a neurologist with EEG and MRI done. Treatment for psychiatric manifestations were given. And on the 3rd day of her admission, she died. And now it's a huge medico-legal issue which is in the court. So very important to never to miss such a condition, because, you know, a first episode behavior problem in an adolescent or young female presenting with symptoms of autonomic overactivity, cognitive impairment, abnormal movements, seizures, and behavioral problems. Always keep this possibility of anti-NMDA encephalitis in your mind. We may have to specifically ask for investigations related to that, because most often, you know, even though the presentation may be catatonic, this is one condition where this may not respond to benzodiazepine therapy. And in fact, giving antipsychotics may really worsen the condition, can lead to a sudden worsening, which happened in this case also. So we have to be very careful about that. And this recent survey of autoimmune disorders presenting with catatonia, 72% of those cases have been anti-NMDA encephalitis. So that is one thing to be kept in mind. Other than that, it was a very extensive presentation and some very intelligent questions from the participants also. I'm extremely glad that so many people from different parts of India joined this webinar, and my congratulations again to Dr. Paneerselvam and IPS Tamil Nadu branch for this wonderful initiative. Thank you very much.
Thank you, sir. Thank you for sharing your knowledge with us. Now I invite our course director, Dr. Paneerselvam sir, to give a concluding remarks.
Thank you, Asiki. Thank you, Dr. Swapnajeet Sahoo, for your wonderful and very elaborative and informative presentations. And more participants stayed till the end of these presentations. I thank Dr. Arunbhi Nair sir for sparing his valuable time to share this session. I thank my colleague psychiatrist, Dr. Vasugi and Dr. Aswad Babu, and all the participants for the patient listening and also participate in the discussion. And the YouTube link is available for the current and the previous sessions. So if you want, you can contact this East Pharma. My special thanks to the East Pharma sponsor. With the East Pharma, what are thanks, you can conclude the session. Over to Naveen.
Thank you, doctors. We extend our gratitude to Dr. Paneerselvam sir, our course director, to conducting such a wonderful program for the benefit of PGs for the past 2 years. And cordially, we extend our gratitude to Dr. Swapnajeet Sahoo sir from PGIMER Chandigarh has a lucid presentation which will be very useful for the psychiatrists across India. Almost 170 participants, they enjoyed the session, and they have very good questions also they have shooted. And Dr. Arunbhi Nair has chaired the program. We extend our gratitude to him also to share his wonderful experience also in this platform. And we extend our gratitude to our moderator Dr. Vasugi and Ashwat Babu sir to have such a wonderful program. Since for the same like type of programs also will be continued in the forthcoming months also. And thank you for benefit of all, and please share these things to your colleagues also in the forthcoming sessions to be benefited. And the YouTube link is available with our Research Pharma YouTube channel, so you can contact our Research Pharma team. Also, you can directly contact to my WhatsApp number also. Thank you so much, and have a great day to all.
Thank you, sir. Thank you, Nair sir.
Thank you. Thank you so much. Thank you.